Hi all, this is Dr. Muhammad Al-Mala, and want to try YouTube live streaming to show and discuss cataract surgery. So I'm just going to show you a case here today, pretty straightforward cataract case. I'm really hoping to use this avenue as a way for us to discuss and different cataract surgery techniques and get your input in the comments as far as things that you like about these techniques, things you would do differently, and I really would like this to be as interactive as possible. So, for those who don't know me, I'm an ophthalmologist. I practice in Florida. I primarily do cataract surgery and glaucoma surgery, and I've been in practice for about 12 years. So without further ado, let's go to the video. So this is a patient who's undergoing routine cataract extraction. You can see here I make the paracentesis. We fill the anterior chamber with preservative-free lidocaine, and then after that with viscoelastic, with a dispersive viscoelastic, I use Visco. And then I use 0.12 forceps to stabilize the globe. I don't use a fixation ring. I find this is more efficient. I'm able to fixate the globe then for the rest until I complete the capsulorhexis. I use a 2.4 millimeter keratome blade. And then I do use a cystotome to start the capsulorhexis. I usually try and do a 5 millimeter capsulorhexis. I try to forceps then to complete the capsulorhexis, as can be seen here. Once the capsulorhexis is complete, then we do hydrodissection with balanced salt solution. I like to tent up the anterior capsular edge before injecting, and I find that gives us the cleanest hydrodissection with the least amount of cortical material attached to the capsule. And then also I hydrodelineate. For phacoemulsification, I go in under sculpt mode, and I basically remove a central core, a nice little working space here, and then I use my chopper to reach around the edge of the equator and do a horizontal chop technique. You can see that the lens, the nucleus rotates nicely, even though we didn't really do much rotation with the hydrodissection or hydrodelineation, and we're already removing the first quadrant here. This is a phaco chop technique. And basically we go around and remove the nuclear pieces. I'm using here, you can see that I manually move my phaco handpiece around. It just helps me to eat the pieces a little bit more quickly, a little bit more efficiently. And then we remove the epinuclear plate. And then we want to remove any remaining fragments or pieces that may be present. While I wait for my assistant to ready the irrigation aspiration handpiece, I take some BSS and inject it through the paracentesis. This does two things. It keeps the anterior chamber from getting too shallow, and it also blows out any pieces that may be hiding in the paracentesis or around the paracentesis. Irrigation aspiration, I basically remove the cortical material from the fornix. I do a little bit of polishing of the anterior capsule. I try and remove the subincisional cortical material fairly early on. And then once the cortical material is free, I may do a little bit more polishing of the anterior capsule. And then we also want to, and then I polish the posterior capsule using a Terry squeegee. So this is silicone tipped. Hold on, honey, I'm live streaming. This is silicone tipped, a silicone tipped cannula, and basically what we're doing is removing the epithelial cells centrally. Yeah. And then we fill up the capsular bag with a cohesive viscoelastic, and then we inject the intraocular lens. I use a wound assist technique. Basically, I don't inject, don't put the entire injector into the anterior chamber. Simply place the tip at the edge of the wound. And the intraocular lens unfolds nicely. Then take irrigation aspiration, and I remove the cohesive viscoelastic from behind the lens and from in front of the lens. And then as I'm doing this, I'm also rotating the lens, and this helps to free up any remaining cortical material that may be in the fornix, in the capsular fornix. And then we take BSS and a 30 gauge cannula and hydrate the main wound and the paracentesis to achieve a sealed incision, a self-sealing incision. So we check the incision. Actually, this is a good point. I like to check the pressure in the eye with just the back of the 30 gauge cannula. I find that's the most efficient way to complete this part of the procedure. We check the wounds with a wet cell sponge. The wounds appear to be watertight, and then I like to push on the eye with a wet cell sponge just to make sure there's no egress of fluid if pressure is applied to the globe. And then we remove the ligament and the speculum, and the case is done. So I welcome your comments, any thoughts you have, any other videos you'd like to see in future. I think I would like to start doing more live streams in the future. I think it's actually a lot faster, a lot more efficient than trying to edit these videos and getting them ready for YouTube. So we'll be showing mainly unedited videos and just discussing the cases together. So that's really about it. If you have comments, you can comment below or requests for other types of videos. Can also add those in the future. So thank you all for watching, and we'll see you again when we do another stream.